When you hear the signal tone, please project slide number 1. The Society of Nuclear Medicine presents Audiovisual Program number CEL86, In Vivo Applications of Multinuclear NMR Spectroscopy and Imaging, presented by Thomas G. Perkins, Ph.D.
Today I'm going to spend my first part of this talk essentially going over the basics of spectroscopy and then talk about the ways that we developed over the past few years to figure out where the spectroscopic information is coming from within the body. First and foremost, we have to ask ourselves, why are we even doing this? And main reasons are that P31 and free water suppressed proton spectroscopy may yield some information about what's going on within the body. In other words, increasing the specificity of NMR, which is something that we kind of lack right now from the normal aspects that we use it for. We break this up into various areas. There's normal proton spectroscopy. We can look at just simple fat and water, or we can look at small molecules within the body. Phosphorus spectroscopy, tissue viability, also what's basically going on within the cells. Carbon spectroscopy, we can use this to actually mark what's going on and then trace where the carbon goes. And then there are other nuclei, fluorine, deuterium, potassium, and sodium. And we can look at this either in a normal spectroscopic fashion or in a normal spectroscopic imaging fashion, or so-called chemical shift imaging. If we look at the MR or NMR parameters that are available to us for a given molecule, in addition to getting out the so-called relaxation times, T1, T2, we can figure out how fast molecules are moving, we can tell how many there are, and we can tell much more about the actual nuclear environment by the so-called chemical shift delta. Chemical shift is basically defined or arises from the fact that a nucleus, which is surrounded by a separate electron cloud, feels a slightly different magnetic field than is actually imposed by the static magnetic field. The expression for this is given by this, which essentially we talk about the nuclear shielding constant, or the amount of shielding that the electrons provide to the nucleus. And then we can define this as so-called chemical shift, which is the difference between the shielding parameter for, say, nucleus X and a nucleus which we have picked out as a standard reference. Now, with this in mind, we can then look at what a spectrum actually is. An NMR spectrum actually is a plot of signals versus the frequency at which these nuclei give out a signal. Each of these has in itself three properties: the resonant frequency, the width, which is directly related to a time constant known as T2 star, and the area, which is directly proportional to the amount of nuclei that you have. So we can get some unique information for a given type of nucleus, but then we can tell how much is there as well. Referred to chemical shift before. In a true sense, what we do is we pick out a standard reference signal. We pick out the signal that we want to observe, and then the difference between these two frequencies divided by the frequency of this standard gives us the so-called chemical shift. This is done because, as you can do spectroscopy at different magnetic field strengths, which means different frequencies, this gives you the ability to compare spectra that are acquired at, say, some low field versus some other magnetic field. Thus, when we talk about spectra, we may say, for example, that peak I is 4.3 ppm downfield from the standard reference, which we set to 0. Everything in NMR is done relative. There is no overall absolute scale that we use when defining spectra. Let's look at some of the nuclei that we can observe. Hydrogen is probably the easiest. It was one of the first nuclei that was done. We have a lot of it, H1. It has a spin quantum number of 1/2, which is something that's really nice. Anything that's greater than 1/2, we run into some problems. For virtually all applications, we'll be looking at spin 1/2 nuclei. The mixture of the sensitivity and the isotopic abundance is this term. For hydrogen, that's set to 1.000 for comparison to other nuclei. And as an example, at 1.5 Tesla, 15 kilogauss, 15,000 Gauss magnetic field strength, protons resonate at 63.86 megahertz. Some of the advantages and disadvantages: we have a lot of protons in the body. It's very sensitive, but the spectra in general come out fairly complex, and as I'll show you later on, there are ways that we can simplify these. Because in addition to just being complex, we have cell water, lipids, and other things that essentially wipe out some of the more smaller molecules that we may want to look at within the spectrum. And the chemical shift range is quite small, so we can have a variety of molecules in a very, very small space along the axis. Just a sample spectrum. This is simple carboxylic acid, where we have a CH3 group and a COOH group. Because of these oxygen atoms next to this proton, it appears much further downfield than the normal CH3 protons that we see here. And if you integrate this, you'll find the ratio is 3:1, which is what you expect. So right away we can begin to quantitate things if we so choose to do. Phosphorus 31 is another nucleus that we choose to look at. It's fairly important within the human body. Essentially 100% of all phosphorus in your body is p31. It again has a spin 1/2, which is again something that we like to have for a nucleus. The receptivity relative to protons, though, is much smaller. And if you think about it, the concentration of phosphorus also is much, much less in the human body than it is for normal protons. It resonates also at about 25.85 megahertz. Even though it's virtually 100% p31, we don't have much of it in the body. The spectrum that we can acquire turns out to be much more simple than the proton spectrum, and it has a very large overall ppm range, roughly about 25 parts per million for biological phosphates. One of the main molecules that we're interested in looking at is ATP. We can look at these three phosphate groups and then get some idea of what's going on within the body. This is what a phosphorus spectrum looks like in the human head. Here are the three phosphate groups from the ATP molecule. We can also look at phosphocreatine, phosphodiesters, diphosphoglycerate, sugar phosphates, and PI, inorganic phosphate. This is kind of important because in normal human body, your ATP gets broken into ADP, inorganic phosphate is formed, and then work ultimately arises. To go back, oxygen comes in with some substrate, ADP, you go back to ATP. Under high workloads, and in some cases for tissues that are somewhat cancerous or other types of tissues, there isn't enough oxygen to support what's going on. Phosphocreatine can be broken down to creatine, and ADP goes to ATP. Summarized here, glycogen goes on through, tack on some phosphate groups, begin to spit out some ATPs here. If oxygen is present, we get a whole bunch of ATPs coming out through the normal Krebs cycle. If not, you'll have this mechanism going on, and lactate is then formed. Turns out that this can be monitored also from the phosphorus spectrum because the p31 signals are sensitive to pH. So if you look at the phosphocreatine resonance or the any monophosphate peak, you can plot this as a function of pH. So we can actually observe pH changes within the body. So right away we've got a few things that we can observe from the phosphorus spectrum to give us some idea of what's going on within the body. Carbon-13, strictly mention it because it's something of some interest. Predominantly you're carbon-12, not carbon-13, so we only have about 1% of your body is carbon-13. Spin quantum number is 1/2 again. It's a nice nucleus to observe. Its sensitivity relative to protons, though, is way down. So from a practical standpoint, for doing normal carbon-13 images, you're probably looking on the order of days compared to minutes for protons to collect a carbon-13 image. So this isn't very practical. Resonant frequency is about 16 megahertz at 1.5 Tesla. Clearly, we've got carbon throughout the body, but its sensitivity relative to phosphorus is really quite low. And since phosphorus is low relative to protons, you can get an idea of how bad this can be. There isn't much of it, And in some cases, if you want to isolate a particular carbon resonance, you have to decouple it from protons that are bound to the carbon-13. This can create a potential hazard. Essentially, you can cook your patient or your sample that you're looking at. So this is something that is a concern. The chemical shift range, however, is quite large. It's greater than 200 parts per million, and this can be used very well. This is a carbon-13 spectrum of the temple. This has coupling still present. This is the resonance from normal fatty acid chains. The reason there are 3 peaks is because of the 2 protons that are attached. Decoupling would remove this, but it would also heat up the individual. We can pick out other signals from other carbons as well. The applications for this, I think, primarily lie in terms of tagging different molecules with carbon-13 and then tracing where they go within the body. This is a rat, follow feeding of C13 labeled glucose, and you can see resonances begin to build in and grow and appear at different locations with time. Now you kind of have the basics of what we can observe. I want to spend the next part of my talk discussing how we get the information. The basic scheme that people have more or less come up with over the past 4 or 5 years has been to place what we call a surface coil or a small RF coil on a given part of the body, set up the acquisition, collect the data, produce a spectrum, and then get useful information out. The problem with this scheme initially was that we could take a human being, put a surface coil on, excite this large volume and get out a spectrum. But when we did that, we would get information from the whole head. We wouldn't get it from just one location. So that essentially, although we'd like to look at the water and small molecules within the brain, we're picking up lipid from the outer part of the scalp. So this isn't really very useful. Showing as an example, here we are in the head and the thigh. Yes, we can see some lipids in the thigh, but we're also picking up water from the muscle. This is more from the outside. The real question became, how do we begin to localize this information? Now, there are a lot of schemes that we can look at. Some involve using the same magnetic field gradients that you use to generate an image, and others involve using the RF to localize where things are coming from. First touch over in this area, which essentially is using the sensitivity of the RF to determine where the signals are coming from, and then I'll go into so-called gradient methods, which can produce images as well as normal spectra, but localize where the information is coming from. Variable pulse width is actually very simple. Essentially, you change the power that's coming out of your coil, and because of that, depending upon how deep the given molecules are, you will get a signal out. The limitations are we can localize just in terms of depth. It is totally inaccurate. You don't really know where the information is coming from. And you have to know how the coil behaves when it is put onto the patient. This is an example on a human head where we have varied the power, increasing it 2.5 times, and what we find is that the spectrum changes as you go further into the head. Now, part of this is due to the fact that the tissue content changes, but also it has to do with the fact that the RF, or in addition to getting information from a given depth, it's also getting information from both further in and not as far in. So not a very useful method, but an early method that was tried. Another way to play with the RF is to design an RF coil that only selects information from a given volume. This is a kind of a toroid loop gap coil, which has a sensitive profile right through here, which can give us this kind of spectrum. The problem is we've decreased the volume. We're still collecting a liter or so of data from the patient. So if we want to know about one small area, we're not really going to get that from this technique. The next technique that was worked with was using depth pulses. That is, pulsing the RF in such a way that you're much more selective than the previous method. Again, it can be used fairly easily, but it suffers from the same problems. You only are localizing in terms of depth, and again, you need to know what the sensitivity profile of the RF coil is. This example from Tom Schleich out at UC Santa Cruz. This is of a lens. anterior to posterior on an eyeball, and we can track the phosphate spectrum as a function of depth. We can see there's a lot of ATP. On the outside of the lens, as we go inside, we see very little. MDPA begins to show up. But again, we don't know exactly where we are in the lens other than we know that we're at some depth. Third technique, which is more or less the one that's being used today by most groups in the world, is to use the gradients that we generate for imaging to localize where the spectroscopic data is coming from. We can define things in terms of a slice, a line or so-called prism, or actually a volume, some kind of cube. There are some concerns in terms of have to use a very narrow pulse, which may conflict with the fact that we may have a very broad spectrum. The magnetic field homogeneity is something that we really have to worry about here because we're now using magnetic field gradients in conjunction with the magnetic field to localize things. And that if we're using selective methods where we have to use an RF echo pulse, we have to make sure that the T2, or the spin-spin relaxation time of the tissues that we're looking at, is much, much longer than the echo delay. One of the first techniques like this that was developed is the so-called depth-resolved surface coil spectroscopy, or DRESS technique. And essentially, by using a surface coil placed on, in this case, a head, and using a slice selection gradient, we now have defined a disk of data that we then sample, which results in something like this. This is using a surface coil tuned for protons. At the surface, we can see we have roughly 60% water to 40% fat. As we go further into the head, we see predominantly water, which is what you would normally see. If we go outside the coil, we don't see anything, and that was primarily done as a test to show that the method really does work. Just some examples of using this. This is a calf muscle with surface coil now placed on the outside, and you can see the penetration profile of the surface coil. You then define, say, a slice in this location perpendicular to this plane. And this gives you a fairly sensitive volume or sensitive disc within the normal calf muscle, which we can generate a proton spectrum. Using a long echo delay, we have effectively suppressed the water signal, and we're now beginning to see a lot of small molecules, lactate, creatine, carnitine, and other molecules that in a normal spectrum, as you saw previously, we have a very large water peak. So this shows one of the concerns that we have in terms of doing spectroscopy is that large signals like fat and water, we have to get rid of those so we can begin to see other things within the spectrum. This shows setting up for an individual to collect a slice of information through the brain. And then this is the spectrum that was then arrived at. Now it's a 10 millimeter axial slice, so we're getting the whole slice of the head. But we have used so-called 1331, which is an RF type pulse that suppresses the water. And we see a lot of things in here. This is a phosphorus spectrum of a calf muscle showing the ATP peaks, phosphocreatine, and other things as well. I will point out that something that we see, which you don't see very often at all, if the magnetic field is shimmed well enough, you begin to see this splitting, which is a hyperfine spin-spin coupling between adjacent phosphorus atoms within the ATP. Now this is all well and good. We collected disks, but we have to get better than that. If we ultimately want to use this in a routine clinical fashion, we need to localize to a small area. And this is where the point-resolved spectroscopy technique comes in. If you define three planes using gradients, you can localize a point or a cube from which you can get the information. So as an example of how this can work in a phantom, this is a dish of water with alcohol inside. You can prescribe or prescribe where you want the data to come from. In this case, we want to collect it from inside the alcohol. And the result is as follows. From that previous selection, we can see the CH3 groups from the alcohol, the CH and the OH. If we now move the sampling volume to outside of there, we see only water. So this is the type of technique that we're really going to need if we ever want to make spectroscopy a routine, practical, clinical type of tool. Another way to localize is using so-called chemical shift imaging, or CSI. Essentially, you end up with an image that within each pixel of that image, you have a chemical shift spectrum. You can end up with both image information as well as spectroscopic information. It takes a long time to acquire these images, and in terms of using this on such things as phosphorus or fluorine, it probably will not happen because it will take too long to sample the data. Here's the chemical shift spectrum. What you're really doing is collecting a series of chemically shifted images, and each image shows a different aspect of the proton chemical shift spectrum. This is some data collected by Dr. Herfkens on a dog. From the upper left to the lower right, we're going from the left to right of the spectrum. So initially we should approach tissues that contain only water, and then tissues which contain only fat. And this is in fact what we see. As we step along, we begin to pick up the tissues which only contain water and end up with tissues that contain only fat. This data can be displayed another way, which is we can display the full composite image, and then from each area we can then pull out the appropriate NMR spectrum. In this case, liver, for example, is predominantly water, which is what we saw in the chemical shift image. And then if we go out to the fatty area, we see predominantly fat with a little bit of water. Only negative thing about this technique is it does take a fair amount of time. This data set took roughly 20 minutes to acquire. It can be done on a human as well. This just shows the liver and the surrounding fat and the spectra from the given areas. Now, the requirements for doing spectroscopy or chemical shift imaging are that the magnetic field strength has to be sufficiently high enough so that the frequency difference between signals can be seen. I'll show an example of that in a moment. The magnetic field homogeneity has to be quite high, however, because you're looking at very subtle part per million differences between signals. If the homogeneity of the magnet is on the order of tens to hundreds of parts per million, then you'll never be able to make out the frequency differences within the spectrum. And the third are field localization capabilities, and these are things that we've and other people have been very active in terms of localizing where the spectroscopic information comes from. As an example of how field strength affects the spectrum, at low field, where you may have two signals that are very close together, those will produce just a single signal. As we increase the field strength, the frequency difference will begin to increase to the point where you'll be able to resolve both signals. And as an example, for phosphorus, if you want to look at the normal phosphorus spectrum at 0.3, 0.75, and 1.5 Tesla, you can see that at 0.3 Tesla, you really can't do anything. At 0.75 Tesla, you're beginning to pull out the signals. And once you get up to 1.5 or beyond, you can begin to resolve things much better. Okay, I'm going to kind of close the session with discussions of what we may be able to do with imaging of nuclei other than just plain old protons. A few fundamental questions we have to understand is this information even going to be diagnostically useful? Can we obtain it in a clinical fashion? And is it practical? Applications that we could be involved with, sodium-23. Sodium can be used or believed to be used in these areas as well. Fluorine-19. I'll show you an example. Using some of these fluorocarbon blood substitutes, we can study tissues. Lithium-7 is just a possibility. Lithium has an NMR active nucleus. And deuterium as well. Very low in sensitivity, but potentially could be used. I've already seen some of this information, but it gives you an idea of what the levels of sensitivity we're facing with other nuclei. Of course, we don't really have any fluorine in the body, so we have to introduce whatever we're going to look at. Protons, of course, exist. Sodium does exist, as well as phosphorus. This is the amount in moles per liter in the body, and you combine that with the relative sensitivity. It turns out that some things just aren't very practical to do. This is a sodium image. This is collected in a 3D acquisition, courtesy of the University of Wisconsin-Madison. This is 4 images, and the other set of 4 that were acquired. This took roughly 15 minutes to acquire in a 3D acquisition. Because we don't have very much sodium in the body and the sensitivity is low, the spatial resolution is set low, so we have much higher signal to noise. So typically these are on the order of a 1 centimeter or so spatial resolution. Now, where it's thought this might be useful, it turns out that the sodium ion concentration is elevated by a factor of 2 or 3 in tumor cells versus normal cells. This is a left frontal lobe astrocytoma, which we see in the normal proton image, edema surrounding the tumor. In the sodium image, it's believed, right here, we're seeing elevated sodium ion concentration within the cells. Example of some work that Sada Kalal has done. This is an example of a recent stroke. You can see right here. This is not seen on the normal contrast enhanced CT. This is seen within 2 hours after the onset of stroke. Same patient who was going to be examined anyway to look at an old stroke, which we can see right here. AVMs, typically these are seen as black in a proton image, but it's not fully perceivable from the image as to how much damage there actually is. In the sodium image, we can see that this extends very much farther than what we see in the proton image. So it's believed there may be some applications of sodium. Show you a cat head because now we're going to look at phosphorus imaging. This is a cat at roughly 1.44 Tesla. This is what the phosphorus 31 chemical shift image looks like with different regions of the head taken out. This is after onset of stroke. We really don't see much ATP. We see primarily just normal inorganic phosphate present within the tissues. This can be displayed in a similar fashion that I showed you earlier with in the proton chemical shift image, where we can observe just phosphocreatine, ATP, inorganic phosphate, and the total phosphate pool. The acquisition time for this was roughly on the order of an hour. So from a clinical standpoint, this probably will not be useful. This is a rat abdomen proton spectrum, and then after being injected Flosol-DA, a fluorinated blood substitute, we can see that the fluorine has been taken up by the liver. The stomach now comes out as being dark, whereas we see some signal from here. Again, although interesting as an experiment, the acquisition time on this image was 3.5 hours. So in terms of usefulness from an imaging standpoint, it doesn't look very good. On the other hand, doing a localized phosphorus spectrum could take much less time. Just kind of as a review, the possible clinical uses of this type of work, sodium in particular, monitoring therapy. If we wanted to follow chemotherapy, radiation therapy, and see whether or not cells are in fact dying off, you can monitor the sodium ion concentration, perhaps. This has been shown and demonstrated in at least 1 or 2 cases so far, and may turn out to be viable in the future. Tissue viability, phosphorus spectroscopy looks like this can be very useful. From an imaging standpoint, probably not. If we can collect a spectrum in the matter of a few minutes, whereas a chemical shift image may take on the order of an hour or so, clearly the spectroscopy will be used. And I think the most important thing for NMR in particular is diagnostic specificity. We don't have specificity right now in NMR. This is something which we think ultimately spectroscopy can be used for this. The long-term goals, I think, from doing all of this work kind of exist as follows. This is a possible future protocol for a patient. After we've localized the volume of interest, we can collect the data. We may want to take this proton data and go off and do some other mathematical operations on the data to pull out parameters such as T1, T2, and proton density, optimize what the image may look like, may do some kind of numerical analysis on these, but then go into either doing, say, something like a sodium image or a phosphorus or also normal proton spectrum. And from this, take this information and use that to analyze what is going on within the patient. With that in mind, I thank you.
That concludes the program. Please rewind this cassette to be ready for its next use. Thank you.